Hello, now I am with Professor Palou. It's a big honor to have you with us. He had a very nice talk about translateral resection. I'd like that you give for Brazilian urologists some take-home messages of your talk, talking about in-block resection, re-TURP. Thank you so much.
Well, okay, it's a pleasure to be here at the AUA and collaborate with the COW, and now to give some short messages to Brazilian urologists. Well, I mentioned a few aspects about urothelial cancer of the bladder and upper tract, but probably some of the messages unrelated to what he was asking about in-block resection. Well, about in-block resection, there are a lot of papers and not clear messages. I think, and we just finished a randomized trial that was done by my colleagues in my center, following the story of bladder cancer in our center. My Dr. Breda and all the team in uro-oncology, that we did a randomized trial in en-bloc resection, and the only really advantage is that the pathologists are happier because the specimen is complete, and also they can do a better staging and sub-staging of T1 disease. The reality is that comparing TURB versus en-bloc, the muscle specimen was the same, 95%, complications were the same, so really there is no real difference. Related to recurrence, later recurrence, we still have a short follow-up. It looks like that en-bloc might be a little bit better, that they say that if we resect, we might have more cell implantation, but we will see in the next few years how the curves go, but now it's not significant. And
And for this case, when you perform in-block, you must do re-TURP again. You still have to do that.
Well, that's another story. re-TURB. Re-TURB, I already mentioned. The most important thing of the TUR is do a first good TUR. Because I mentioned that, and there are several papers showing that the residual disease is about 60% and understaging 15%. And in our center, residual disease is 17% and understaging is 0%. So what does it mean? If you do a good first TR, always go deeper and wider to have really a complete resection. The first one has to be the good one. And the thing is that in our center, having these numbers, what we don't do to all T1 patients re-TUR, only those who are T1B. Perfect. T1A we don't go, high-grade TA we don't go because residual disease is quite low, understaging is 0%. So I think this is an important message. Have a look at your own specimen and pathology of the first TUR. Perfect. Because this is important. And then have a look at your own re-TURs. And if you have good results, probably is not so much needed. This has to be published, and we will publish. I will update our results. Probably we have to change the guidelines, but also we have to change the habits of the urologist to do a better TURB.
The first time. So thank you so much. It was very nice to have you with us. Thank you so much.
A real pleasure. Thank you to all of you.